In the last lecture, we had studied about AKI and chronic kidney disease, where we had discussed how chronic kidney disease is divided into five parts, where one to three parts, the one to three stages, they are the stages which are managed more with the time. But once we reach the fourth and especially the fifth stage, when in this condition, we have to make, we have to upgrade to the, you can say, management part to another level where there are so many medicines which are added, and along with that we have to shift to some other medical management, which we'll be discussing right now. So today now we are starting with the third section of kidney problems. So the first thing which I'm going to discuss is the end stage renal disease. So what is that end stage renal disease? We call it ESRD. So this is also called uremia, which is the extensive retention of urinary constituents. And what are these urinary constituents which are retained? The main composition, we see the composition, that is the urea, which is enhanced in the blood. And then it is a toxic condition of terminal manifestation of the renal failure. It is a condition where we see that the problem with the kidney has magnified manifold, and more than 90% of the functioning renal tissue, they are destroyed, which are leading to this uremia. And then due to the presence of large amount of nitrogenous waste, it is unable to maintain the constant blood pH of 7.4. So that will cause imbalance in the pH of blood also. Now, what is this end stage renal disease? How it is caused? Now, once we know this is the last stage where we need to change the direction of our therapy for the conservation kind of thing, where the disease has progressed to its end stage. Now, we have to see how the management is getting changed. So, just like AKI and the previous type of previous stages of the renal disease which we had seen in the CKD also, the primary reasons are diabetes mellitus, hypertension, and along with that we had glomerulonephritis. And now let us understand the pathophysiology, how that unfolds and how it affects the patient. So let us see. The first thing is what is the starting point of that? That is the inability of the kidneys to perform its normal function. So what are the normal functions of the kidney? The normal functions are to excrete the waste products. Second is to maintain the fluid and electrolyte balance. And the third is to produce the hormones. So all these effects, the main functions, they are affected, and the kidneys, they are unable to perform these three important tasks. And that will lead to the stage which is called, we have just defined that is known as uremia. So that means there are unacceptable level of nitrogenous waste, and especially urea. And now what will be the symptoms of this problem? Once the patient reaches this stage, there will be malaise, there will be weakness, there will be nausea and vomiting, there will be muscle cramps, there will be itching all over, and then metallic taste in the mouth, and some neurological impairment can also be seen. So once the patient reaches this level, so as I had already told you that medical nutrition therapy, that will change. So how the medical management changes? We support the patient with the dialysis or kidney transplant. So the patient has to be prepared either for dialysis or for the kidney transplant, because here now we cannot manage the increasing level of nitrogenous waste and imbalances of the fluid and the electrolytes with only diet and other medicines. So then along with that, immunosuppressant drugs they are given, and then psychological support is provided. So that is the medical management. Now let us see what is the nutritional management. Here the goals of the nutritional management are, the first thing is we have to prevent the deficiencies, because the condition has arrived where the intake of the food and the maintaining the nutritional status of the patient is going to be a challenging task. So here we have to see that we have to prevent the deficiencies, and then we have to control edema and serum electrolyte level. Then we have to prevent renal osteodystrophy. What will happen? Renal osteodystrophy is because of less amount of vitamin D produced. Once there is less amount of vitamin D, there is no manager present inside the body who can manage the calcium level inside our bones and inside our blood. That will cause leaching of calcium from the bones and reaching to the blood, and naturally there will be imbalance. So, and then we have to provide a palatable and attractive diet. So these are the basic goals of nutrition management. So here I had introduced to the topic, that is dialysis. It is a procedure to replace some kidney functions, because we have seen there are basic three functions. So we would like to replace those functions with the help of dialysis. So once the person is experiencing more than 95% kidney failure, the patient is recommended dialysis or kidney transplant. An indication, what are the indication? The creatinine clearance is 4 to 8 milliliter per minute, or serum creatinine above 10 milligram per deciliter. The patient is recommended dialysis. Then it removes the excess fluid and waste from the blood. As I have already told you, we'll be discussing it again. Then it will help in maintaining the safe level of blood chemicals. And then how it will work? The blood is circulated through a dialyzer, and the blood is bathed by the dialysate. So how it will function, we'll see. So these are the different types of dialysis. So here we'll be discussing two types of dialysis. The first one is hemodialysis, and the another one is peritoneal dialysis. Hemodialysis is a dialysis where uh, the purification of the blood or the treatment of the blood that will happen outside the body of the patient, whereas in the peritoneal dialysis, the same procedure, the dialysis will happen inside the peritoneal cavity of the patient. So here we can see the hemodialysis. This is the image where you can see it is usually It usually happens 3 times a week, and each treatment lasts from 2 to 4 hours. And during treatment, patient can read, write, sleep, talk, or watch TV. So let us see how this hemodialysis acts, how this hemodialysis works. So here, what you can see, this is the patient, and now this blue line where you can see the blood is coming out of the body, that is the removed blood for the cleaning. And now here there is a arterial pressure monitor which will monitor the blood pressure of the patient. And now the blood goes to the blood pump, from where it will go to this is another heparin pump is planted here to prevent the clotting of the blood. The heparin is a substance which will prevent the clotting of blood, because the blood is outside the body of the patient. And here we have inflow pressure monitor, which will see at what pressure we need to send the blood inside and at what space it has to go inside. Now here, this is the main unit. We call it dialyzer. So here the dialysate will be mixed with the blood of the patient. So you can see from here, there is the fresh dialysate is entering, and from here the used dialysate is going in the another chamber. Now, after the treatment, the blood is sent back to the body through another channel. So this is how our uh, hemodialysis works. So here we have a semi-permeable membrane and solute removal that helps via that is removed via the passive diffusion. And this passive diffusion, I'll be showing you in another slide. It is the how the pace and the things which are going to be removed from the blood, they will be dependent upon the size of that molecule. So the bigger is the size of molecule, the difficulty is to getting rid of that. So it is this hemodialysis is effective in removing potassium, urea, and calcium, but chloride ion, but not the phosphate ion, because the phosphate ion is a bigger ion. So uh, here we can see the mechanism of solute and fluid exchange, how this happens. On the left side, you can see there's blood, and on the right hand side, you can see this dialysate. So this is a semi-permeable membrane. So from the blood, urea will go to dialysate. The bicarbonate that will be going from the dialysate to the blood. So this will manage the pH. Sodium level, see there are two-way process. Sodium level will be dependent upon the level in the blood. That will be there in equilibrium. Sodium can move this way or that way depending on the condition. If we see the patient has more sodium in the blood, we will put less here so that the sodium that reaches the dialysate. And with the pressure, we will be sending fluid to the dialysate, and then other small molecules such as chloride, they will be pumped with the help of ultrafiltration and the bulk flow. So this is how the exchange of different solutes that will happen in the dialysis. I'm skipping these slides. Now let us go to the complications of hemodialysis. Because the blood is moving out of the body of the patient, so the chances will be the patient might get some generalized infection, or it could be septicemia, that is the septic condition inside the blood. Then fevers and chills could be experienced. It could cause hypothermia, because blood is drawn out of the body, and then hypotension could occur, that means less blood pressure, low blood pressure, muscle cramps, hepatitis C, and then catheter clotting. They are the complications which could happen with the dialysis. Now coming to the second type of dialysis, that is known as peritoneal dialysis. Here the peritoneal membrane, which is a partially permeable membrane. Partially permeable membrane is a membrane which may permit few things to pass, but which may not allow others to pass. That is partially permeable membrane. So peritoneal membrane is the membrane inside the peritoneal cavity of the patient. So the catheter is surgically placed to create an excess. We'll be creating an excess, and dialysate, which we saw in the hemodialysis also, dialysate is filled through the catheter, and diffusion and osmosis will happen here also. Same thing, diffusion is free exchange to and fro depending upon the level, and then osmosis. Osmosis is the movement of any fluid or liquid from from the thicker concentration to the uh, something which is not that thick. For example, uh, if the level of sodium is very high in the blood, we will keep the level in the low in the dialysate. So the sodium will be pushed out of the blood to maintain an equilibrium. So this process is known as osmosis. And after the exchange, used dialysate is drained from the cavity. Now, let me show you. You can see this. This is a figure of peritoneal dialysis. Here we see the dialysate is going inside the peritoneal cavity of the person, and it is kept for the dialysis process, and then it is the used one is drained out of the body. And now vascular excess is not required. We need less dietary restriction once the person is going on the dialysis, and it can be scheduled whenever the patient feels convenient. So this is a very busy slide where we will see what is the dietary recommendation for the different type of conditions where either the person is going for a dialysis, it could be hemodialysis or it could be peritoneal dialysis. Peritoneal dialysis, in fact, it could be intermittent or it could be continuous. So we have little differences in these two conditions. And then uh, post transplant, post transplant of the kidney, 4 to 6 weeks we have some other guidelines, and after the 6 weeks we have some other little changes in the guidelines. So if we see for the energy, it is 35 for hemodialysis. Again, 40 to 50 for depletion we have to give if the person is on intermittent peritoneal dialysis. If the person is on continuous dialysis, then again we have to give him 25 kilocalorie per kg ideal body weight. For the transplant person, we have to give 30 to 35%, and uh, for the after the 6 week, it has to be in order to achieve the ideal body weight. And for protein, if we see, for all the reasons, for hemodialysis it is 1 gram per kg body weight, it's normal. We are not restricting protein now, uh, because there are losses which are going to happen in the dialysis process. For intermittent peritoneal dialysis, that is IPD, it is 1.2. For CAPD, it is 1.2. And for transplant, we have to give very high protein. For few around 6 weeks, it is 1.5 to 2 grams per kg ideal body weight. And after 6 weeks, it is returned to 1. Now coming to the fluid values. For hemodialysis, here we have to see what is the urine output, and we have to give an allowance of 500 ml more. And then it is same. But for the CAPD, where continuously the dialysis is happening, so here you see there is drastic change. We are giving 2000 ml per day plus the urine output. And there are no restriction for the transplant patients. And if we see the sodium, again, the value will be dependent upon the existing value of that patient. Some person who has high sodium value in the blood, that will vary. And for intermittent in CAPD, it is approximately 2 to 3. And for CAPD, since the losses will be more, you will see more values are RDA. It is 6 to 8 grams per day. And for potassium value, it will be 2 to 3 grams per day. And then for CAPD, again, because the losses will be more, it will be 3 to 4 grams per day. And for phosphorus, you will see 1 to 1.2. And for CAPD, it will be 1.5 to 2. And here, for the transplant and post-transplant patients, you will see there's intake of calcium. Along with the phosphorus, we are giving calcium 1 to 2 grams per day. So this was an overview of dietary management during the dialysis phase and the transplant. Now we are coming to the last part of the kidney disorders, that is urolithiasis, urinary calculi, or the kidney stones. So they are crystalline mass which are lodged in the urinary tract. It could be in the kidney, it could be in the ureter, it could be in the bladder or urethra, any part of that urino system, bladder system. So they are the small foci of mucoid structure. It's a proteinaceous structure where small foci will be formed, where urinary salts, they will precipitate. So you can imagine a small dot where some hard salt that will be there, that will encase that foci, and that will cause the formation of a stone. So for the protein metabolism, we know the uric acid is produced. That is a normal product of kidney metabolism. And here uric acid, phosphate, and oxalate, these are the three things which are of concern. Now, any urine with high level of calcium phosphate, ammonium phosphate, that will lead to stone formation. And if a person is having extra acidic urine, which causes uric acid or calcium oxalate crystals, hence the person with which has extra acidic urine, he will get uric acid or calcium oxalate stones. Interestingly, if the patient has alkaline urine, the pH is higher. So what will happen? This will lead to triple phosphate, calcium carbonate, calcium phosphate crystals. So again, there will be stones, but they will be of a different kind. So let us see what is the occurrence and symptoms of these kidney stones. It is usually there in the warm climate, and it is common with the people who are working directly under sun, and they are precipitating a lot, and that concentrates the urine. And if the person has some infection, if the diet is rich in oxalates, calcium, purines, phosphates, tea, sodium, fat, meat, sugar, and if the diet is low in fiber. So these are the you can say things which gives you more there, which causes more chances of getting this problem, of getting the stones. And then heredity, and then male gender is more prone to getting these urinary acids. Now symptoms, there will be renal colic, pain in the kidney, severe and continuous pain which begins in the back and travels towards the bladder. There will be nausea, there will be vomiting, there will be urinary tract complications, there will be urgency. The patient would like to use washroom. He will go to the washroom again and again, and there will be inability to urinate. Now, let us see what are the different types of stone. We have been introduced to these. Now, let us see. The first one is the calcium oxalate stones. They are the most common type of the stones which are promoted by reduced urine volume, blocked urine flow, increased concentration of the urine, and stone forming substances when they are more. There is more calcium oxalate in the blood, so this will cause this type of calcium oxalate stone. So how do we manage? We will manage the stones based on the source, on the type of the stone. So let us say calcium and magnesium phosphate and carbonate stones, they will lead to alkaline urine. When there is phosphate and carbonate stones, then the diet will be acid as ash diet, because the urine has turned alkaline. We will give something which will produce more of acid. So the diet will be acid ash diet. And we have to maintain the urine pH between 4.5 to 5. And if we have uric acid stones, then we will give them alkaline ash diet. And if we have oxalate stone, we will give them low oxalate diet. So we have 3 types of treatments. If the stone is of phosphate and carbonate stone, and the patient is having alkaline urine, we will give him acid ash diet. And if the person is having uric acid stones, we will give them low purine diet along with alkaline ash diet. And if we have oxalate stones, definitely we'll give them low oxalate diet. So these are, this is a slide which has summarized again the type of stone and what should be the target. Now let us just peep into what is acid ash diet. It increases acidity of the urine. It will contain chloride, phosphorus and sulfur. Now here what we are suggesting to give, we will give them meats, cheese, grains. They are to be emphasized, and we have to restrict fruits and vegetables, and we give them in the limited amount because they have alkaline ash. So exceptions are corn, lentil, cranberries, plums, and prunes, which can be given in acid ash diet. So now we come to alkaline ash diet. So what is that? It increases alkalinity of the urine. So again, here we have to go for a reverse stage. It contains sodium, potassium, calcium, and magnesium. So here again, we will be suggesting fruits and vegetables. And exceptions are again corn, lentil, cranberry, plums, and prunes, because they will produce more of acid. So meats and grains, they are to be limited, again because of their acidic nature. Now coming to the low oxalate diet, if in case the patient has oxalate stones, here we will give moderate protein, which will come from milk and curd, and other than that, the foods are to be avoided. Especially the protein foods, they are to be avoided. And here we have to exclude beets, greens, green leafy vegetable, spinach, tomato, potato, chocolates, cocoa, coffee, tea, cola, yam, and cashew nuts. So because they are high in oxalates, rest the patient can take the other things in normal amount. So this was all about different type of kidney diseases, where we had discussed the different type of problems associated with kidney, be it problems associated with nephrotic syndrome, or some AKI, or chronic CKD, with the different stages ending from starting from the first stage to the end stage renal disease, where we have to support the patient to the dialysis. And we had also discussed the kidney stones test.